Thank you so much, Louis. To follow up from yesterday's discussion, we thought this is an interesting thing because we're discussing ventricular arrhythmias today. I thought I'll show you some of the data on neuromodulation, a little bit of science,
Un poco de
but also
ciencia,
very
pero
important
también.
data that is coming from South America, and it's a great opportunity for us because we collaborated with FCI. So this is UCLA, and again, you met all my colleagues, including Dr. Ajijola, who's here. But many of these doctors have been a part of our studies. And we also have a neurocardiology research program, which is why this is the scientific group. And we also have this collaborative consortium of 7 universities that are now mapping the nervous system of the heart, which is what we're going to be talking about. So what has been the major findings that I want to bring to your attention? Sudden death. Sudden death is a huge problem. It's estimated somewhere between 8 to 12 million people die suddenly every year. And of course, we spend most of our time, at least in America, is dealing with ICDs and patients who actually have very bad ventricular function. If this problem is stated differently, if you look at the much bigger picture of the entire population at risk for sudden death, and really look at the people who are dying suddenly, it's only we spend all our time looking at this small part of the circle. And yes, as a percentage of this group, yes, there are more people dying suddenly, but if you look at the actual number of people dying suddenly, there are way more people who actually don't even have such severe heart disease. They probably have cardiac scars. So these are the patients that I think are the great opportunity for us to have a global impact. Catheter ablation, today you're hearing this session. It's very interesting, it's very important. This was the first multi-center data set that was put together. There's been a series of about 8 papers that have been published to date using the International Vt Ventricular Tachycardia Ablation Consortium. And in fact, we've invited FCI, and hopefully we'll get our good friends from INCOR to be a part of this, because this should be an international consortium. And for the first time, we showed, using this consortium effort, that, and this, of course, you can see that Dr. Maturia is a good friend of ours, and also Dr. Natali's program, Texas Arrhythmia, they were part of this consortium, along with UPenn, Dr. Garcia's program, and Dr. Stevenson's program, which is Brigham. And of course, UCLA coordinated this database. So if you have ventricular tachycardia, and if you can make sure that you don't have VT recurrence after VT ablation, there is a mortality benefit. It's a very useful procedure to do. Whereas in structural heart disease, if you have VT recurrence, that really is a terrible mortality rate. If you think about it, up to 30% of people die within 1 year if you don't fix this. And again, catheter ablation of VT, here's a little picture that I put up just for today's case. This is another way of ablating septal VTs. You can actually coil embolize through the coronary artery, and this is actually intraseptal ablation using coils. So the reason I just put up those slides is VT ablation is very sophisticated, as you're seeing today. You can do whatever techniques that are needed to fix this. But then, if you're ablating in the heart and if you cannot fix it in the heart, what do you do? So you have to go to another level. That's where the neuraxial therapies come up. And as it turns out, there are many levels of the nervous system that you can actually work on to control VT. If you look at medical practice, and all of us see general cardiology patients, so if you look at the entire field of heart failure, all the medications that are used for treating heart failure modulate the autonomic nervous system. Beta blockers, ACE inhibitors, angiotensin receptor blockers, all these are autonomic modulating drugs. So this is, of course, in the guidelines, and it's worth remembering, now, can we now do this in a more strategic, scientific way? So a quick word about anatomy. We saw this slide yesterday, and again, I'm highlighting the fact that the heart, like all other organs, has its own nervous system, which is the intrinsic nervous system. It also has extracardiac intrathoracic ganglia, the stellate ganglia that controls the heart, then the spinal cord, and of course, you have nerve fibers that send impulses to the brain stem, and that controls the heart in the efferent side, which is sympathetic and parasympathetic. So all that is colored in blue is information going from the heart to the nervous system. So the heart is a sensory organ. So we often forget that. So any nerve that goes to an organ has information going both ways. So the way the nervous system controls organs is like the internet. So we now refer to this as the internet of the human body, of how we modulate this, and many other diseases, not just heart disease, inflammatory diseases, rheumatoid arthritis, they're all being now looked at from a neural perspective. So the heart itself has the intrinsic neurons that we talked about, and these are the big targets for atrial fibrillation therapy. And these are the ganglionic fat pad that sit at various locations, and they control both the atria and ventricular electrophysiology. What is new in this field is we now can image and look at the heart more scientifically. This is data using a technique called clarity, where you can actually make a heart transparent by replacing the lipids, so you can see through the heart. And once you do that, and if you use confocal lasers, you can actually see the entire nervous system of the heart. This, of course, allows you to see the actual neurons. This is the little brain that sits in the heart. This is what I showed you yesterday, where people are injecting Botox to control AFib. And we can use more advanced techniques, such as what you're seeing here is referred to as light sheet microscopy. And what you see over here is an entire heart that has been imaged. And in this case, we have stained it with various antibodies for nerve fibers. So you can see the entire nervous system controlling the heart, and you can actually image this, and now you can look at this in very high resolution data sets. And this is the work that was done by Rosemary and Pradeep at UCLA. So why is the physiology of this is important? It's actually incredibly important because of the fact that the heart needs to react within seconds if the body needs it. So right this minute, if we heard a fire alarm, all of us should be immediately ready to get up and run, and our heart rate will go up. And that is the nervous system controls all these functions, the heart rate, the electrical function. In fact, we now know it even controls metabolism and healing and regeneration. So the example that I gave you, if the fire alarm went off right now, you will instantly have sympathetic excitation. That is from the cortex to the heart. Similarly, what we don't quite often remember is if you have a scar in the heart, or even if you pace the heart abnormally, you're talking about CRT. Sometimes patients have right ventricular pacing that causes dysynchrony. If you do that, that can also cause sympathetic excitation. And that exactly is what happens in heart failure. And it turns out we now can record from various parts of the heart, including the actual neurons on the surface of the heart. This is a left ventricular pressure tracing, and these are neuronal recordings on a beating heart. And I can show you now that if you look at some of these neurons, they are like beautiful sensors in the heart. This is a neuron that senses the actual contraction of the heart. So the nervous system knows every heartbeat, and not just the heartbeat, it tells you what state of your heartbeat is, whether it's relaxing or whether it's contracting. And here's another example where we are recording from multiple neurons, and you're just touching the heart, and you can see that some neurons shut off, some are activated. So this actually shows you can directly record from neurons on a beating heart. So once you have that, you can actually listen to the heart, and you can understand how the nervous system is talking to the heart, and use that neural signature for understanding therapeutics. So we can also do more advanced techniques. Here's an example where we've just used something called channel rhodopsin in a neuron in the heart, and we shine light on the heart, and you can see that without electrical stimulation, in this case light stimulation, you can control specific subsets of neurons. Let's say you put an electrode over here, you're going to pace all these neurons, whereas if you express the channel rhodopsin just in one or two of these specific cell types, you can get selective neuronal stimulation. This is the kind of experiments that are being done to understand how nerves control the heart. So this is an exciting thing. This is the whole optogenetic revolution that is happening in neuroscience. Now, what about pathophysiology? This is one important slide. It's very practical. When the heart is injured, or you have myocarditis, you have Chagas cardiomyopathy, it doesn't matter. This injury to the heart actually sends signals to the brain, and this activates the renin-angiotensin system. And we try to interrupt this process because that's what causes remodeling and heart failure. This is a huge problem, as I told you, globally. And what has happened in the past 15 years, our group and others have done a lot of basic science studies, both in animal models, but most importantly in humans. And we have found that there is remodeling of the nervous system at the level of the heart, the stellate ganglia, and of course the spinal cord and the higher centers. And this is something that as disease progresses, because of cytokines that are circulating, they powerfully affect the innervation of the heart. So we also know that if you injure the heart and if there is an infarction, here is data that Pradeep recorded. You can record neurons on a beating heart after creating an infarct, in this case an experimental infarct, recorded from the fat pad. This is exactly the area where Dr. Valrabano was actually using a wire to map a VT. This is what is sitting right around his wire is a bunch of neurons that are controlling the heart. So when you do these kinds of experiments and measurements, you now know that the heart knows that it's infarcted. In fact, the heart can even know that it's being paced in an abnormal way. So for the first time, we've been able to record a neural signature from the heart, and we now know what information it's sending to the brain, which causes the whole problem of heart failure. Is this relevant? We're ablating PVCs today. So this is a paper that just came out. You can look at this online. It's freely available online because this is NIH-funded research. And here's an example where we do high-density mapping of the heart, and we're putting in PVCs while doing neuronal recordings. And this is an example of a patient who has variable coupling PVCs, which actually cause VF. And one of the interesting findings that we had in this particular study is if you look at the post-extrasystolic beat compared to the sinus beat, the presence of a PVC, especially one that has a varying coupling interval, completely disturbs the repolarization of the heart. Perhaps this is the neural signature that increases the risk of VTVF. So nerves are very, very important. Nerves powerfully control the heart. Why do I say that? Here's an example of a completely normal heart. And all we are going to do now is to start stimulating the nerve. And look at what happens. When you stimulate the nerve, you instantly go into VF. So this shows how powerful nerves are in controlling electrical propagation. It also follows that when you have a scar in the heart shown over here, and in this case we are actually pace mapping within a scar, you get various VT exit morphologies. So the interaction between this substrate and functional control is why you get ventricular tachycardia, shown over here. This is the cartoon showing VT. And you're going to be seeing cases today. We map here, get to the site, you can entrain, you can pace map, you can actually look at late potentials and interrupt ventricular tachycardia. And the beauty of this is if you cannot fix the problem in the heart, do neuromodulation. How do you go about doing neuromodulation? You can work on the sympathetic nervous system, or you can work on the parasympathetic nervous system. Working on the sympathetic nervous system, there are many, many opportunities. You can start with thoracic epidural, work with the anesthesiologist. You can inject lidocaine into the stellate ganglion. And of course, you can surgically do sympathectomy and also spinal cord stimulation and also renal denervation. All our management techniques that you've seen, published guidelines tell us the things that we use to support a patient are all neuromodulatory drugs or interventions, I must say, beta blockers, sedation, neuraxial modulation. So neurons have interested us. So let's talk about stellate ganglia. Here's a beautiful picture for you to look at. This is Dr. Cajal, who won the Nobel Prize, showing how delicate these neurons are, the ones that control the viscera, in this case, also the neurons that control the heart. We know that if you actually can surgically interrupt and remove this neurons from the circuit, you can control VT. Why do we know this? This is data. This is Dr. Ajijola has this paper that's coming out. One of his mentees has published this. This is a survey of all the available papers in the literature, which actually shows that if you inject lidocaine into the stellate ganglia, you can control VT. These were patients, of course, who had to meet the criteria for actual good reporting. And this is across numerous studies, almost every available paper in the English literature. We and others, and of course our group, has really focused on this now for almost 15 years. We have actually seen that thoracic epidural anesthesia and stellate ganglion may control VT. So we published this paper in 2010 when Tara Burke was with us, and of course my colleagues Dr. Basegi and Ajijola were here. a part of this effort. And we know that cardiac sympathectomy has been used since 1961. This is the first report that came out of Duke University. Dr. Zipes also reported this in 1968, where they did bilateral cardiac sympathectomy. And we know from the work of Gaetano Di Ferrari and Peter Schwartz that this can be used for patients who have channelopathies, long QT syndromes, CPBT. We were talking to our colleagues from Argentina about this. So this is incredibly effective. Why? Here's an example of coronary occlusion in this canine model. You can see there's VT. If you do sympathectomy and do the same experiments of coronary occlusion, you don't get VT. So why does sympathectomy work? I'll show you one piece of data, and then I'll show you clinical data before I conclude. Here's an example where we do experimental coronary occlusion in a canine model, and we are measuring direct catecholamines in the myocardium at a total of 6 locations: infarct zone, peri-infarct zone, and remote zones. And if you measure the catecholamines that are released during coronary occlusion, when you occlude the coronary, you see that the catechol levels, norepinephrine levels, shoots up. And of course, and when you reperfuse it, it washes away, it comes down. And if you look at what happens to animals that develop ventricular fibrillation and compare that to ones that don't develop ventricular fibrillation, if you look at the peri-infarct zones, the animals that are VF susceptible have a greater amount of catechol that is released. So there is more release of norepinephrine, which is very arrhythmogenic. This can be mitigated by neuromodulation. And in fact, in this particular study, we were able to precisely show that if you measure norepinephrine levels in the normal zone, border zone, and remote zones, and if you had the entire nervous system in fact intact versus cutting off the stellate ganglia, or by doing spinal cord stimulation, which the data I have not shown on the slide, you can actually reduce the amount of catechol that is being released. So what this tells you is the information going from the heart to the brain amplifies sympathoexcitation. And it actually makes sense. You think about it, right? If you get scared and worried, you get more sympathoexcitation. This, of course, is real life, and this is a paper that I'm very fond of because this is collaborative work. This comes with an international study, Johns Hopkins XSR, and FCI is a part of this. And in this study, thanks to our collaborators right here in Bogota, we were able to show for the first time that bilateral cardiac sympathectomy is superior to just doing left stellate alone. And this can be done with a very low risk of complications and side effects. And I really think that, if you get a chance, many of you can look at the editorial online and also a very detailed, nice audio commentary that Dr. Valentin Fuster has provided for this particular study. So we are planning to do a prospective study where we want to actually take patients who have failed Vt ablations and randomize them to regular treatment versus sympathectomy. And in the future, this may not necessarily be surgical. We may be able to actually do this even by using electrical control of nerves, using special techniques called kilohertz frequency AC current and charge balance DC current. And there are 2 papers that are in press in Journal Heart Rhythm for those of you interested looking at it. And this actually experimentally shows that you can reduce VT inducibility. In this case, you're not doing surgically, but you're using bioelectronic modulation of nerves. So all this is quite exciting. And in the future, we are also going to be seeing more studies using vagal nerve stimulation, which is a big area of interest for my colleague, Dr. Basegi. We know that for many, many years that you can terminate VT by vagal stimulation, shown over here. In this case, you're doing carotid sinus massage and you're terminating VT. So, and why does that happen? This is a study that was done by my colleague, Dr. Basegi, and this is a paper that's in press in JCI Insight. And in this particular study, we show that the ventricular action potential can be lengthened by vagal nerve stimulation. And this actually has direct neurotransmitter measures, and you can see that the VT inducibility goes down by vagal nerve stimulation. So I'll leave you with the last thought saying that there are a lot of interesting neuromodulation cures that are around the corner. It's already working for the heart, but other diseases, even liver diseases, inflammatory diseases, are going to be using neuromodulatory therapies. And I'll just leave you with another thought. 22 people die suddenly every minute in this world. So we need low-cost, globally applicable therapeutics. And to do that, we really need to spend our life thinking about what we're going to do for all these patients. And I think that's what keeps us excited. And to quote a gentleman from my country, if you want good neuromodulation, learn to meditate. And I suppose instead of tea, you can have good coffee if you're in Colombia. So I'll stop here, thank my colleagues, and I appreciate you letting me give the talk now because I have to head to the airport. And if there are comments or questions, I can take them. Thank you so much, Louis.
Thank you very much, Chief, for this great talk. Absolutely great. Is maybe one of the best example that how to join basic investigation research applied to clinical. So it is amazing. Unfortunately, you have to go to the airport. No hay tiempo para preguntas para el Dr. Chief. Ya tiene que tomar.
Or you can ask Louis.
Bueno, thank you very much for.